Welcome to Bookfulness. This is episode 8 in our focused deep dive into Moore's clinically oriented anatomy. Our previous episode, if you remember, laid the groundwork. We looked at the shoulder region, the neurovasculature, the muscles, really set the stage. Because that shoulder complex, it's arguably the body's most intricate link between, the trunk and the moving limb.
Indeed it is. And today, we're pushing on, continuing our exploration of Chapter 3, upper limb. We're zeroing in specifically on pages 374 through 417.
Right.
Our goal today is to move distally from the shoulder. We want to give you a really focused, structured, and importantly, clinically relevant look at the axilla and the arm itself.
So mapping out those neurovascular highways, this seems like
the pathways that run through this area. Understanding them is absolutely crucial for clinical practice. Think diagnosis of nerve injuries, performing regional anesthesia. It all starts here.
Okay, so let's start with the axilla. I think maybe we need to give it a bit more respect than just, calling it the armpit.
Ah, definitely. It's much more than that.
Anatomically, you described it as a sort of pressurized pyramidal distribution center.
That's a great way to put it. It's the main hub. It's where the entire upper limb's blood supply and wiring gets sorted out before it heads down into the arm proper. Okay, let's define that space properly. When we talk about the axilla, anatomically, we're talking about a pyramidal area. Think of it like a four-sided pyramid lying on its side.
Okay.
And it acts as this protected channel. It's formed by bones and muscles, giving it an apex, a base, and 4 distinct walls. Visualizing that pyramid shape really helps you understand why the structures inside are so vulnerable, yet also quite protected.
So if it's a pyramid, where's the tip, the apex?
Good question. The apex, or the superior boundary, points inwards and upwards towards the root of the neck. It's actually a passageway, a gateway, known as the cervico-axillary canal.
Ah, okay.
And this canal, this passageway, is defined by 3 structures. You've got the lateral border of the first rib medially, the clavicle anteriorly, and the superior edge of the scapula posteriorly.
Pretty tight space then.
It is relatively tight. Everything vital heading to the limb arteries, veins, nerves has to pass through that narrow gateway.
Got it. And the base, the part we actually, see as the armpit.
Right. The base is the inferior boundary. It's that concave floor you can see and touch. It's formed by the axillary fascia, which is just deep fascia, along with skin and subcutaneous tissue.
And you mentioned something about it being dynamic.
Yes, what's interesting is that this fascial floor isn't static. When you abduct your arm, lift it away from your side, this fascia is pulled upward. There's a specific ligament, the suspensory ligament of the axilla, which is actually part of the clavipectoral fascia from the chest wall that pulls it taut, creating that characteristic depression we call the axillary fossa, the armpit hollow.
That's neat how the fascia connects things. Okay, so we have the apex and the base. What about the walls containing everything?
Right. The 4 walls, they're almost entirely muscular. The anterior wall, the front wall, is formed mainly by the pectoralis major. And just deep to it, you've got the smaller pectoralis minor muscle and the associated clavipectoral fascia.
Okay.
The posterior wall is generally thicker, more substantial. It involves the subscapularis muscles superiorly, and then inferiorly, the teres major and the edge of the powerful latissimus dorsi muscle. These form that posterior axillary fold you can pinch.
Yeah, those are big muscles. Lots of protection there. What about the sides, medial and lateral?
The medial wall, that's the side against your ribs. It's formed by the upper thoracic wall itself, the first 4 ribs or so, and the overlying serratus anterior muscle.
Ah, the serratus anterior. That's the one involved in winged scapula if its nerve is damaged.
Exactly. The long thoracic nerve runs right on its surface. So damage here is clinically significant. That medial wall is really important for scapular stability.
And the lateral wall?
The lateral wall is surprisingly narrow. It's basically just the intertubercular sulcus, that groove on the humerus bone. Not much of a wall, more like a bony landmark where tendons run.
So this protected dynamic space is actually inside it. That's the crucial part, right?
Absolutely vital. The contents are the main event. We're talking about the axillary artery and its branches, the axillary vein and its tributaries, lymph nodes, and critically, the major nerve bundles the cords of the brachial plexus.
And they're not just loosely floating in there. There's some organization.
There is. And this is where the fascial organization becomes a really key clinical concept. The major neurovascular structures, the artery, the vein, and those brachial plexus cords are all enclosed together, bundled within a single, distinct connective tissue sleeve.
Okay.
This sleeve's called the axillary sheath.
Right. Why is that sheath so important clinically? It's just connective tissue, isn't it?
Well, yes and no. It's much more than just connective tissue. Functionally, it's a direct extension of the deep cervical fascia, specifically the prevertebral fascia that descends from the neck right down into the axilla.
Okay, so it connects the neck to the armpit structurally.
Precisely. And clinically, it's a prime target. Think
Yeah.
about a brachial plexus blunt.
For surgery on the arm, right, to numb the whole thing.
Exactly. An anesthesiologist often injects the local anesthetic solution directly into or very close around this axillary sheath. Because it's a contained fascial compartment, the anesthetic diffuses within it, bathing the cords of the brachial plexus.
Ah, so it reaches all the major nerves efficiently.
Perfectly. You get sensory and motor block of the upper limb distal to the shoulder. So, knowing the exact location and extent of this sheath, it's absolutely fundamental for performing a successful, safe nerve block.
That really reframes the axilla. Less of a simple pit, more of a highly controlled neurovascular compartment,
Right.
essential for distribution and regional blockade.
You got it. It's a critical anatomical hub.
Uh-huh.
Okay, let's trace the main artery. As the subclavian artery comes out from under the clavicle and passes the lateral border of the first rib, it immediately changes its name.
It becomes the axillary artery.
Correct. And its entire course through the axilla, and importantly, the organization of its branches, is classically defined by its relationship to one specific muscle.
The pectoralis minor, that small muscle deep to the pec major.
That's the one. It acts as the key landmark. We use the pectoralis minor to divide the axillary artery into 3 distinct parts. It's a system that, thankfully, is quite logical and even has a nice mnemonic associated with it.
Right, the 1, 2, 3 branching pattern. Makes it easier to remember.
It does. So the division is indispensable for anatomical study and clinical reference. The artery is divided into 3 parts relative to the pectoralis minor. Part 1, the section of the artery medial to the pectoralis minor muscle before it passes underneath. Part 2, the section posterior or deep to the pectoralis minor. Part 3, the section lateral to the pectoralis minor after it emerges from behind the muscle.
Okay, medial, posterior, lateral relative to pec minor, and the mnemonic.
The mnemonic relates to the number of branches that typically arise from each part. 1 branch from the first part, 2 branches from the second part, and 3 branches from the third part.
1, 2, 3. Nice and simple, totaling 6 main branches.
Exactly. 6 branches in total off the axillary artery proper.
Okay, let's run through them quickly to build that mental map. Part 1, the most proximal bit, medial to the muscle. Just 1 branch.
That's right. The superior thoracic artery. It's usually a fairly small vessel, but it's important for supplying structures right at the top of the axilla, things like the subclavius muscle, the upper parts of the pectoralis major and minor, and maybe the first couple of intercostal spaces.
Got it. Now, part 2, tucked directly behind the pectoralis minor, we get 2 branches here.
We do. The 2 branches arising from the second part are the thoracoacromial artery and the lateral thoracic artery.
Thoracoacromial. Sounds like it goes to a few places.
It does. It's interesting because it usually pierces the clavipectoral fascia quite soon after arising, and then it quickly splits into 4 terminal branches, typically a hectoral branch for the pec muscles, and a acromial branch for the acromion area, a clavicular branch, and a deltoid branch. So it covers that whole anterior shoulder and chest region.
Okay. And the other one from part 2.
The lateral thoracic artery. This one runs down along the lateral border of the pectoralis minor, following the medial wall of the axilla. It mainly supplies the serratus anterior muscle.
The muscle on the medial wall we mentioned.
Exactly. And it also gives off branches, especially in females, that are quite important for supplying the lateral part of the breast tissue.
Right. Okay, that's part 2. Finally, part 3. This is the longest segment, lateral to the pectoralis minor, and it gives off 3 branches.
3 major branches, yes. These are significant vessels. First, you have the subscapular artery. This is typically the largest branch of the entire axillary artery.
The largest. Okay.
It arises near the lower border of the subscapularis muscle and almost immediately divides into 2 important terminal branches, the circumflex scapular artery and the thoracodorsal artery. The subscapular artery system is absolutely fundamental because its branches participate heavily in the collateral circulation around the scapula. We'll come back to that.
Okay, subscapular is number 1 from part 3. What are the other 2?
The other 2 are the anterior circumflex humeral artery and the posterior circumflex humeral artery. As their names suggest, they circle around the humerus,
Which part?
around the surgical neck of the humerus. The anterior one is usually smaller, running in front. The posterior one is larger, runs behind with the axillary nerve through the quadrangular space, and is the main supply to the deltoid muscle and the shoulder joint itself.
Got it. So we have this neat 1, 2, 3 system for the branches. But you mentioned collateral circulation. That sounds like the really crucial clinical story here. It's about the resilience of the blood supply, right? Or
Yeah.
sometimes the lack of it.
Exactly right. Collateral circulation is the body's backup plan. It relies on anastomosis, basically, connections or networks between different blood vessels. So if the main highway, the axillary artery, gets blocked or narrowed, occluded, blood flow can potentially be rerouted through these smaller, interconnected side roads, the collateral arteries.
And this works well if the blockage happens slowly, like with disease.
Generally, yes. If the occlusion happens gradually over time, say due to atherosclerosis building up plaque, these smaller anastomotic vessels, especially those around the scapula involving branches of the subclavian and the subscapular arteries, have time to enlarge. They hypertrophy.
They get bigger to handle the increased flow.
Precisely. They adapt and can often provide sufficient blood flow to the rest of the arm, preventing tissue death or ischemia.
But the problem comes when the blockage is sudden.
That's the critical difference. Sudden occlusion may be from a trauma causing a laceration or a sudden blood clot, or even intentional surgical ligation is much more dangerous. If the main flow stops abruptly, those collateral pathways haven't had time to develop and enlarge. They simply can't handle the volume needed. The blood supply to the arm, forearm, and hand quickly becomes inadequate.
And the textbooks really emphasize a specific danger zone for surgical ligation regarding this collateral flow.
They do, and it's a critical surgical principle. If you have to tie off or ligate the axillary artery during surgery, where you ligate it matters immensely for the outcome. The most vulnerable segment for ligation is the portion of the third part of the artery located between the origin of the subscapular artery and the origin of the profunda brachii artery.
Okay, why is tying it off right there so bad?
Because ligating it there cuts off the main roads, both into and out of the collateral network at that level.
Yeah.
You're distal to the massive collateral input coming from the subscapular artery system around the scapula. So you lose that major upstream backup supply.
Right.
And at the same time, you're usually proximal to the origin of the profunda brachii artery, which is the main vessel supplying the deep structures of the arm itself, branching off just below the axilla. So you effectively isolate the distal limb from both its main supply and its major collateral routes. Ischemia is highly likely in that scenario.
So the surgical goal, if ligation is unavoidable, is to ligate proximal to the subscapular artery.
Ideally, yes, or at least preserve connection to it. Ligation proximal to the subscapular artery allows blood flow from the subclavian artery territory to potentially get around the blockage via the scapular anastomosis and re-enter the circulation via the subscapular artery, thus perfusing the distal limb.
Makes sense. Okay, let's switch quickly to the venous side, the axillary vein. It's draining the arm, running with the artery.
Yes, the axillary vein is the major venous channel draining the upper limb. It's a large vein. It generally runs anterior and slightly inferior, or anteromedial, to the axillary artery. Importantly, it's usually within the axillary sheath alongside the artery and plexus cords.
And how is it formed?
It begins down at the lower border of the teres major muscle, typically formed by the joining of the paired brachial veins, which accompany the brachial artery in the arm, and the large superficial basilic vein, which comes up the medial side of the arm.
So it collects blood from both deep and superficial systems.
Correct. And as it ascends through the axilla, it receives tributaries that generally correspond to the branches of the axillary artery. It then passes the lateral border of the first rib and becomes the subclavian vein. Its size and close relationship to the artery are really important clinically during surgery or trauma. Accidental puncture can cause significant hemorrhage or even air embolism if air gets sucked into the vein, especially if the injury is near the neck, where venous pressure can be negative.
All right, shifting gears a bit now to the lymphatic system within the axilla, the axillary lymph nodes. These are hugely important clinically, right? Especially in cancer staging, like breast cancer.
Hugely important. The axilla acts as a major drainage basin for lymph fluid for a vast territory. Unlike the main vessels and nerves, these lymph nodes aren't typically inside the axillary sheath. Instead, they're embedded within the axillary fat and connective tissue surrounding the sheath.
And what areas do they drain?
They receive lymph from the entire upper limb, arm, forearm, hand. But also, critically, from a large area of the trunk wall, basically the entire superficial body wall of the upper quadrant, extending from the level of the clavicles down to about the level of the umbilicus, and from the midline out laterally. This includes, very importantly, the majority of the lymphatic drainage from the breast.
Wow, that's a huge catchment area. Anatomists usually divide these nodes into groups, don't they, based on location?
Yes, they're typically organized into 5 principal groups. It helps to think of them arranged somewhat like a filtering chain, although the flow isn't strictly sequential through all groups for all lymph.
Okay, what are the groups?
You have 1. The pectoral or anterior nodes. These lie along the medial wall of the axilla, near the lateral thoracic vessels, deep to the pectoralis minor. They primarily receive lymph from the anterior thoracic wall, including most of the breast. 2. The subscapular or posterior nodes, situated along the posterior axillary fold and subscapular vessels. They drain the posterior aspect of the thoracic wall and the scapular region. 3. The humeral or lateral nodes, located on the lateral wall of the axilla, usually just medial or posterior to the axillary vein. These are the main recipients for almost all the lymph coming from the upper limb itself.
Okay, so those three, pectoral, subscapular, humeral, seem like the initial receiving stations from different regions. Where does the lymph go from there?
Much of the lymph from those 3 groups then drains towards the central nodes. These are typically larger nodes situated deeper within the axillary fat, often near the base of the axilla, close to the second part of the axillary artery. They act as a sort of secondary collection point.
A central clearinghouse.
Yeah.
And the final step?
From the central nodes, the lymph ascends to the apical nodes. These are located right at the apex of the axilla, clustered along the axillary vein near the cervico-axillary canal, partially behind the upper part of the pectoralis minor. They are the final common pathway within the axilla. It's worth noting, too, that some lymphatics, particularly those following the cephalic vein, might bypass the more inferior nodes and drain directly into the apical group.
So ultimately, everything funnels towards those apical nodes at the top.
Pretty much. And the efferent lymphatic vessels leaving the apical nodes then converge to form the subclavian lymphatic trunk.
And that trunk drains.
It typically drains either directly into the venous system near the junction of the internal jugular and subclavian veins, the venous angle, or, especially on the left side, it may drain into the large thoracic duct first, which then empties into the venous system.
That detailed pathway makes it crystal clear why surgeons meticulously examine and often remove these nodes during breast cancer surgery. Blockage or removal, especially the apical nodes, must have consequences.
Oh, definitely. If that final outflow pathway is blocked by tumor cells or compromised by surgical removal or radiation therapy, lymph fluid can back up in the limb. This leads to chronic swelling, a condition known as lymphedema, which can be quite debilitating.
Right. Okay, a really important system. Now, let's pivot from lymphatics to the nerves, the organizational masterpiece that is the brachial plexus.
Ah, yes, the brachial plexus. It's the major nerve network responsible for virtually all motor innervation and cutaneous sensation for the upper limb. It originates high up in the neck. It's formed by the anterior rami, sometimes called ventral rami, of the lower 4 cervical spinal nerves, C5, C6, C7, C8, and the first thoracic spinal nerve, T1.
So 5 spinal nerve contributions. These are called the roots of the plexus.
Correct. Those 5 anterior rami, C5, C6, C7, C8, T1 are the roots. Think of them as the initial inputs. Sometimes there are small contributions from C4 or T2, but C5 to T1 is the standard configuration.
And these roots don't just run straight down. They start merging pretty quickly.
They do. As they emerge from between the anterior and middle scalene muscles in the neck, these roots quickly unite to form 3 larger nerve bundles called the trunks.
3 trunks. How are they formed?
It's a consistent pattern. The roots of C5 and C6 join to form the superior trunk. The root of C7 continues on its own as the middle trunk. And the roots of C8 and T1 join to form the inferior trunk. So you go from 5 roots to 3 trunks. This initial organization happens in the posterior triangle of the neck, superior to the clavicle.
The text we're following, Moore's, highlights something it calls the topographical principle. It says that even though these nerve fibers mix and match extensively within the plexus, their original spinal segment origin still dictates their ultimate function distally.
This is probably the most crucial concept for clinical understanding of the brachial plexus. It's the foundation for diagnosing nerve injuries based on functional loss. Think of the spinal cord segments not just as anatomical levels, but as controllers of function, generally progressing from proximal to distal down the limb, C5 and C6. These upper segments primarily supply the muscles acting at the shoulder, like the deltoid for abduction, the rotator cuff muscles, and the main elbow flexors, like the biceps and brachialis. So think shoulder and elbow flexion power. C7 and C8. These middle segments tend to innervate muscles that extend the elbow, triceps, and most of the muscles in the forearm responsible for wrist and finger flexion and extension, midlimb control, T1. This lowest segment is almost entirely dedicated to supplying the small intrinsic muscles of the hand, the ones responsible for fine motor control, grip strength, finger abduction, and adduction. Purely discal function.
Wow. So if you have an injury high up, say affecting the superior trunk, which carries C5 and C6 fibers, you'd expect a specific pattern of weakness reflecting that proximal control loss.
Absolutely. That's the classic presentation of an herb Duchenne palsy, or Erb's palsy. It often happens from excessive stretching between the neck and shoulder, like during a difficult birth or a fall landing hard on the shoulder. You damage the superior trunk, C5, C6. The result: paralysis or weakness of the deltoid, supraspinatus, infraspinatus, biceps, brachialis.
So the arm just hangs.
Pretty much. The arm hangs limply at the side, medially rotated because the external rotators are out, extended at the elbow, flexors are out, and the forearm is pronated. It's often called the waiter's tip or porter's tip position. The person can't effectively lift their arm or bend their elbow.
And conversely, an injury lower down affecting the inferior trunk carrying C8 and T1.
That leads to a Klumpke paralysis or Klumpke's palsy. This is often caused by sudden, forceful abduction of the arm, like grabbing onto something to break a fall, which stretches the lower roots trunk. Here, the C8 and T1 fibers are damaged. The proximal muscles controlling the shoulder and elbow are usually fine, but the T1 innervation to the intrinsic hand muscles is lost.
Leading to problems with the hand itself.
Exactly. Profound weakness of the small hand muscles, difficulty with fine motor tasks, and often a characteristic claw hand deformity, where the metacarpophalangeal joints are hyperextended and the interphalangeal joints are flexed due to the imbalance between the paralyzed intrinsic muscles and the still-working extrinsic muscles. Understanding this topographical link between spinal level and function is absolutely key for localizing brachial plexus injuries clinically.
Okay, so we have roots forming trunks in the neck. As the plexus travels down, passing over the first rib and under the clavicle toward the axilla, it reorganizes again. The trunks split into divisions. Why this extra step? Why not go straight from trunks to the final nerves?
That's a great question. The divisions represent the next crucial step in functional organization. It's where the plexus sorts itself out based on the fundamental plan of the limb, anterior versus posterior compartments.
Flexors versus extensors.
Precisely. Each of the three trunks, superior, middle, and inferior, divides into two divisions, an anterior division and a posterior division. And here's the elegant part. All the nerve fibers destined to supply the muscles in the anterior flexor compartments of the arm and forearms travel through the anterior divisions. Conversely, all the fibers destined for the posterior compartments travel through the posterior divisions.
Wow. So that functional split, flexors forward, extensors back, is hardwired right here as the plexus passes the clavicle.
It's established right there. It's like the nervous system sorts the signals into flex pathways and extend pathways very early on. This segregation ensures coordinated function down the limb.
That makes so much sense. It's like anatomical highway lanes being designated. Okay, so these divisions, 6 in total, 3 anterior, 3 posterior, then recombine almost immediately within the axilla, right, to form the cords.
Correct. As the divisions enter the axilla proper, they converge around the second part of the axillary artery to form the 3 cords. And the cords are named very simply based on their relationship to that artery.
Lateral, medial, and posterior cords.
Exactly. The lateral cord lies lateral to the second part of the axillary artery. It's formed by the union of the anterior divisions of the superior and middle trunks, carrying fibers primarily from C5, C6, C7. The medial cord lies medial to the artery. It's essentially just the continuation of the anterior division of the inferior trunk, carrying fibers primarily from C8, T1. The posterior cord lies posterior to the artery. And this one is formed by the union of all 3 posterior divisions from the superior, middle, and inferior trunks, carrying fibers from C5 all the way down to T1, but all destined for posterior compartments.
Okay, wait. The posterior cord gets input from all 3 posterior divisions.
Yes.
So if the posterior divisions carry all the extensor information, that means the posterior cord is like the consolidated master extensor cable for the entire limb.
That's a perfect way to think about it. It bundles together virtually all the innervation for the extensors of the shoulder, elbow, wrist, and fingers. It's a remarkable consolidation of function.
That's incredibly efficient organization. Okay, so from these 3 cords, lateral, medial, posterior, wrapping around the axillary artery, we finally get the major nerves that run down the arm.
Yes, the cords give rise to the main terminal branches, as well as some smaller collateral branches within the axilla. Morse provides detailed figures and tables listing all the branches, but focusing on the 5 main terminal nerves arising from the cords is key.
All right, the big 5.
1. From the lateral cord, you get the musculocutaneous nerve, supplies anterior arm muscles, and the lateral root of the median nerve. 2. From the medial cord, you get the ulnar nerve, supplies some forearm flexors and most intrinsic hand muscles, and the medial root of the median nerve. 3. From the posterior cord, you get the axillary nerve, supplies deltoid and teres minor, and the large radial nerve supplies all posterior arm and forearm muscles.
Hold on, the median nerve gets a root from both the lateral and medial cords.
It does. The lateral and medial roots typically converge anterior or lateral to the third part of the axillary artery to form the complete median nerve. This union forms a characteristic M or V shape around the artery.
So the median nerve is truly drawing fibers from both the C5-C7 contributions via the lateral cord and the C8-T1 contributions via the medial cord.
Exactly. It makes the median nerve incredibly multisegmental, carrying fibers from potentially all 5 roots, C5-T1. This reflects its extensive role in supplying most of the forearm flexors and crucial muscles in the hand, particularly for thumb movement. And that's a key point Moores emphasizes. Most nerves arising from the plexus, especially the major terminal ones, are multisegmental. They contain nerve fibers originating from several different spinal cord levels, which adds to the complexity but also provides some redundancy.
Okay, let's bring this back to the clinic. A patient presents with trauma, maybe a penetrating injury to the axilla, and you suspect a brachial plexus injury. How does a clinician use this intricate map of roots, trunks, divisions, and cords to figure out what's damaged?
It starts with a very careful neurological examination. You need to systematically test muscle strength and sensation throughout the upper limb. For motor function, we assess the power of individual muscles or muscle groups. We need to distinguish between complete paralysis, meaning absolutely no detectable voluntary movement, and incomplete paralysis or paresis, where movement is present but weak. This helps gauge the severity. Is the nerve likely severed or just compressed or stretched?
And sensation testing is just as important, using the dermatomes.
Absolutely critical.
Right.
Because the sensory territories, the dermatomes, map fairly reliably back to specific spinal cord root levels. For instance, if a patient has numbness or altered sensation, paresthesia, specifically over the lateral aspect of the shoulder, that strongly suggests involvement of the C5 root or nerves derived primarily from it, like the axillary nerve.
And if it's the pinky finger and medial side of the hand?
That's classic T1 territory, usually indicating involvement of the inferior trunk or the medial cord or the ulnar nerve itself distally. You test sensation using light touch, pinprick for pain, maybe temperature, by carefully mapping the pattern of both muscle weakness, which muscles, flexors or extensors, proximal or distal, and sensory loss. You can pinpoint the lesion within the plexus with remarkable accuracy. Is it affecting the roots high up, the trunks, the cords down in the axilla, or a specific terminal nerve branch?
The clinical box in Moores also mentions the danger of direct compression within the axilla itself, like from poorly fitted crutches.
Yes. Crutch palsy is a classic example. Prolonged, incorrect pressure in the axilla from the top of a crutch can compress the neurovascular structures. The cords of the plexus, particularly the posterior cord, which lies closest to the humerus here, are vulnerable. You can also compress the axillary artery. Compressions of posterior cord can lead to weakness in the muscles supplied by its branches. The axillary nerve, difficulty abducting the arm, and the radial nerve, wrist drop, inability to extend elbow, wrist, fingers. So correct crutch fitting and usage instructions are really important.
Okay, let's move out of that complex axillary junction box and down into the arm itself. Anatomically, the arm is the region between the shoulder joint and the elbow joint.
Correct. The brachium.
And structurally, just like other parts of the limb, the arm is organized based on compartmentalization.
Yes, the principle of fascial compartments is key here too. The humerus bone acts as the central pillar. Extending outwards from the humerus to the tough outer sleeve of deep fascia, the brachial fascia, are 2 strong connective tissue sheets, the medial intermuscular septum and the lateral intermuscular septum.
Like walls dividing the space.
Exactly. These septae effectively divide the arm into 2 distinct functional compartments. 1, an anterior or flexor compartment. 2, a posterior or extensor compartment.
And this compartmentalization isn't just structural, it's highly functional, right? Streamlines muscle action and innervation.
Absolutely. It's incredibly efficient. Muscles within the same compartment generally share the same primary action, flexion in the anterior, extension in the posterior. And critically, they typically share a common nerve supply.
So one nerve basically runs the whole front compartment and another runs the back.
Largely, yes. The anterior compartment is primarily innervated by the musculocutaneous nerve, which comes off the lateral cord carrying C5, C6, C7 fibers. It controls elbow flexion. The posterior compartment is innervated by the radial nerve from the posterior cord, C5, T1 fibers, though mostly C6, C8 functionally in the arm. It controls elbow extension. This maintains that functional split flexors anterior, extensors posterior that was established way back in the brachial plexus divisions.
Okay, let's look inside the anterior compartment first. Home to the flexors. There are three main muscles here.
Three key muscles: the famous biceps brachii, the deeper brachialis, and the smaller coracobrachialis.
Everyone knows the biceps brachii. Two heads, right?
That's right. Biceps means two heads. It has a long head, whose tendon runs through the shoulder joint itself, originating from the supraglenoid tubercle of the scapula, and a short head, originating from the coracoid process of the scapula, alongside coracobrachialis. Because both heads originate from the scapula, the biceps acts across two joints, the shoulder and the elbow. Its primary actions are flexion of the forearm at the elbow and also, very importantly, powerful supination of the forearm, turning the palm upwards.
The book goes into some detail about when the biceps works best. It's not just about lifting heavy things straight up.
No, its efficiency depends heavily on the position of the forearm and the angle of the elbow. Here's the key. The biceps is a much more powerful supinator than it is a flexor, especially when the elbow is already flexed. When your forearm is pronated, palm facing down, the biceps tendon is sort of wrapped around the radius, putting it at a mechanical disadvantage for flexion. In this position, it primarily acts to unwind the radius to supinate the forearm. It becomes a truly efficient flexor only when the forearm is already supinated, palm facing up, and its maximum force for flexion is generated when the elbow is bent to roughly 90 degrees.
So that classic bodybuilding bicep curl with the palm up is actually leveraging its optimal mechanics.
It is. And think about functional activities. The biceps is essential for forceful supination tasks. The classic example is using a screwdriver to drive a screw into hardwood or pulling a cork out with a corkscrew. That twisting motion while flexing, that's peak biceps activity.
So if the forearm is pronated and you try to flex your elbow, the biceps isn't the main player.
It contributes, but the real workhorse in that scenario, and indeed for pure flexion in any forearm position, is the muscle lying deep to the biceps.
The brachialis.
The brachialis.
Yes. It originates from the anterior surface of the humerus and inserts primarily onto the coronoid process and tuberosity of the ulna. Because it attaches to the ulna, which doesn't rotate during pronation-supination, its only job is to flex the elbow joint. It does this regardless of whether your forearm is supinated, pronated, or in a neutral position. It's the main power flexor.
The muscle that always works for flexion.
Got it.
And the third one in the anterior compartment.
The coracobrachialis. It's smaller, runs from the coracoid process, like a short head of biceps, down to the medial side of the humerus shaft. It mainly helps with flexing and adducting the arm at the shoulder joint and resists shoulder dislocation. It's pierced by the musculocutaneous nerve, which is a key identifier.
Okay, that covers the anterior flexors. Now let's slip to the posterior compartment, extension territory, dominated by the triceps. Almost exclusively. The triceps brachii is the great extensor of the forearm at the elbow joint. As the name implies, triceps means three heads.
Long, lateral, and medial heads.
Correct. You have the long head, the lateral head, and the medial head. The lateral and medial heads originate from the posterior surface of the humerus. But the long head is unique.
Why's that?
Because it originates from the infraglenoid tubercle of the scapula, just below the shoulder joint socket. This means, like the biceps, the long head of the triceps crosses two joints, the shoulder and the elbow.
So it can act on the shoulder, too.
Yes, it helps extend and adduct the arm at the shoulder. But perhaps more importantly, because it crosses the shoulder joint inferiorly, it plays a critical role in stabilizing the head of the humerus. It helps prevent downward dislocation of the humerus, especially when the arm is adducted or carrying weight. It acts as a dynamic ligament, essentially.
A stabilizing shunt muscle. That's often overlooked. But the main job of all three heads together is elbow extension.
That's their primary collective function, yes. Straightening the arm. The medial head is considered the workhorse for routine extension, with the lateral and long heads kicking in for more forceful extension, especially against resistance.
And this powerful insertion onto the olecranon process of the ulna relates to a common elbow injury, doesn't it?
It does. The common triceps tendon inserts firmly onto the olecranon, the bony point of the elbow. A common injury mechanism is a fall directly under the point of the elbow, often combined with a sudden forceful contraction of the triceps trying to break the fall or push away.
And the bone breaks off?
Often, yes. It results in an avulsion fracture, where the triceps tendon literally pulls his bony attachment, the olecranon fragment, away from the rest of the ulna. Because the triceps muscle is always under some tension, muscle tone, and actively contracts, this fragment is usually significantly displaced proximally, pulled upwards. This almost always requires surgery, usually pinning or wiring the fragment back in place to restore the extensor mechanism of the elbow. Without repair, the person can't effectively extend their elbow against gravity or resistance.
Makes sense. Is there any other muscle in the posterior compartment?
There's one small helper muscle, the anconeus. It's a small triangular muscle located on the posterolateral aspect of the elbow. It runs from the lateral epicondyle of the humerus to the lateral side of the otelicon and upper posterior ulna.
What does it do? Just assist the triceps?
It does assist the triceps weakly in elbow extension, but its main roles are thought to be stabilizing the elbow joint during pronation and supination, and possibly tensing the joint capsule to prevent it from being pinched during extension. It might also help slightly abduct the ulna during pronation. It's a minor player compared to the triceps, but still part of the posterior compartment group. All right, let's track the main artery down the arm. Remember the axillary artery. As soon as it passes the lower border of the teres major muscle, which forms part of the posterior axillary fold, it officially changes its name.
It becomes the brachial artery.
Correct. The brachial artery is now the primary arterial supply for the arm itself, and it continues down towards the elbow.
And its course is clinically important because it's quite superficial, isn't it? You can feel it.
Yes, it's relatively superficial throughout most of its course, especially in the distal arm. It lies on the medial side of the arm, initially medial to the humerus, then gradually spiraling anteriorly. It's nestled between the biceps anteriorly and the triceps posteriorly, often running alongside the medial border of the biceps in the medial bicipital grooves.
And that's where you can feel the pulse and where you listen for blood pressure.
Exactly. You can easily palpate the pulsations of the brachial artery in that groove, especially just above the elbow. And yes, this is the standard site for placing the stethoscope bell when measuring blood pressure using the auscultatory method, listening for the Korotkov sounds as you deflate the cuff.
As the brachial artery runs down the arm towards the elbow, the cubital fossa, does it maintain a constant relationship with the main nerves, specifically the median nerve?
Its relationship with the median nerve is important and changes. Proximally in the upper arm, the median nerve typically lies lateral to the brachial artery. However, as they descend towards the middle of the arm, the median nerve usually crosses anterior to the artery. So by the time they reach the cubital fossa at the elbow, the median nerve lies medial to the brachial artery.
That crossover point is important to remember. What about major branches coming off the brachial artery in the arm?
The largest and most functionally significant branch is the profunda brachii artery, also known as the deep artery of the arm. It usually rises quite high up, near the beginning of the brachial artery.
Profunda means deep, right? Where does it go?
It immediately dives posteriorly, passing through the triangular interval along with the radial nerve. It then spirals around the back of the humerus within the radial groove. Its job is to provide the main blood supply to the entire posterior-extensor compartment of the arm, the triceps muscle.
So brachial artery mainly supplies the anterior compartment. Profunda brachii supplies the posterior.
Broadly speaking, yes. The brachial artery also gives off smaller muscular branches to the anterior compartment, a humeral nutrient artery that enters the bone shaft itself to supply the bone tissue, and typically two collateral arteries near the elbow, the superior ulnar collateral artery and the inferior ulnar collateral artery.
Collaterals again. Important for around the elbow joint.
Very important. These collateral arteries descend to participate in a rich network of anastomoses around the elbow joint, connecting with recurrent arteries coming back up from the forearm, radial and ulnar recurrent arteries. This network ensures blood supply to the joint and distal structures, even if the main brachial artery is compressed or occluded during elbow flexion.
Okay, that covers the artery. What about the veins draining the arm? You mentioned deep and superficial systems earlier.
That's right. The venous drainage has two parallel systems. The superficial veins are the ones you can often see just beneath the skin, especially in leaner individuals.
Like the ones they use for IV lines.
Often, yes. The two main superficial veins of the arm are the cephalic vein and the basilic vein. Both originate from the venous network on the back of the hand, the dorsal venous arch. The cephalic vein travels up the lateral side of the forearm and arm. Think anatomical position, thumb side. It runs in the groove between the deltoid and pectoralis major muscles, the deltopectoral groove, before diving deep to join the axillary vein. The basilic vein travels up the medial side of the forearm and arm, pinky finger side. It runs more superficially initially, then pierces the deep fascia about midway up the arm to run deeper alongside the brachial artery.
And there's a connecting vein between them at the elbow, the clinically famous one.
Ah yes, the star of venipuncture, the median cubital vein. This vein runs obliquely across the roof of the cubital fossa, the triangular depression on the front of the elbow. It provides a connection, shunting blood from the cephalic vein laterally to the basilic vein medially.
And why is that vein the preferred site for drawing blood?
Several reasons. It's usually large, easily accessible, and well anchored by the surrounding fascia, so it doesn't roll away easily. But anatomically, a key reason is safety. The median cubital vein often lies directly superficial to a tough fibrous sheet called the bicipital aponeurosis. This aponeurosis stretches medially from the biceps tendon across the cubital fossa.
Acting like a protective roof.
Exactly. It provides a layer of protection, separating the superficial median cubital vein from the deeper, more critical structures within the fossa, namely the brachial artery and the median nerve. This reduces the risk of accidentally puncturing those structures during venipuncture.
Makes sense. So that's the superficial system. What about the deep veins?
The deep veins run alongside the arteries and share their names. In the arm, the main deep veins are the brachial veins. The key feature is that they are typically paired two veins flanking the brachial artery.
Paired. Why two?
These paired, often interconnected deep veins that closely accompany an artery are known as venae committantes, literally accompanying veins. This arrangement is common in the limbs. One important physiological reason for this close association, especially in the limbs, is thought to be countercurrent heat exchange.
Countercurrent heat exchange. How does that work with veins and arteries?
Think about maintaining core body temperature. Warm arterial blood flows from the core down the limb. Cooler venous blood returns from the periphery back towards the core. By having the returning veins wrapped closely around the outgoing artery, heat can transfer directly from the warm arterial blood to the cooler venous blood before the arterial blood reaches the very distal parts of the limb, like fingers and toes, where heat would be easily lost to the environment. It helps conserve core body heat in cold conditions. It's a neat piece of thermal engineering built into our anatomy.
That is fascinating. Such elegant efficiency. Okay, let's focus on that elbow region where everything seems to converge.
Yeah.
The cubital fossa. You described it as a triangular depression.
Yes, it's an important anatomical landmark on the anterior aspect of the elbow. Its boundaries are quite distinct, superiorly, the base of the triangle. An imaginary horizontal line connecting the medial and lateral epicondyles of the humerus, the bony bumps on either side of the elbow. Medially, the lateral border of the pronator teres muscle, a forearm muscle originating near the medial epicondyle, laterally. The medial border of the brachioradialis muscle, another forearm muscle forming the lateral bulge, laterally. The apex of the triangle points downwards, where the pronator teres and brachioradialis muscles meet or overlap.
Okay, so those muscles form the sides. What about the floor and the roof?
The floor of the fossa, the deep surface, is formed by two muscles. The brachialis muscle superiorly, the main elbow flexor we discussed, and the supinator muscle inferiorly, a deep forearm muscle. The roof is formed by skin and superficial fascia, but importantly, it's reinforced by that bicipital aponeurosis we mentioned, stretching across from the biceps tendon. The median cubital vein runs in the superficial fascia of the roof.
Got it. And the critical contents within the fossa, deep to the aponeurosis, there's a standard order, right? A mnemonic.
There is. A very common mnemonic to remember the main contents from medial to lateral is NAT, or sometimes MBBR, but NAT focuses on the core three. Nerve. The median nerve. It lies most medially within the fossa proper. Artery. The brachial artery. It lies just lateral to the median nerve. This is where it usually bifurcates into its terminal branches, the radial and ulnar arteries, typically near the apex of the fossa. You can feel its pulse here, medial to the biceps tendon. The biceps brachitendon. It lies most laterally of these three structures, diving deep to insert onto the radial tuberosity just below the elbow joint.
Nerve, artery, tendon, medial to lateral. That's easy to remember. Is the radial nerve in there too?
The radial nerve is in the vicinity, but it's technically lying deeper, between the brachialis and brachioradialis muscles, just lateral to the biceps tendon. It's usually dividing into its superficial sensory and deep motor branches around this level, slightly outside the main NAT grouping.
Okay. We've traced the vessels. Let's quickly recap the paths of the four main nerves as they traverse the arm, highlighting any vulnerabilities. Musculocutaneous.
Musculocutaneous nerve. Comes off the lateral cord, pierces the corca brachialis muscle, that's its signature move, then runs between biceps and brachialis, supplying all three anterior compartment muscles. It becomes purely sensory, lateral cutaneous nerve forearm, below the elbow. It's generally well protected within the muscle mass. Injury is uncommon unless there's direct trauma to the anterior compartment.
Radial nerve,
Uh,
definitely more exposed.
Highly exposed, yes.
Well,
Comes off the posterior cord, passes posteriorly with the profunda brachii artery, and lies directly in the radial groove, or spiral groove, on the posterior aspect of the humerus shaft. This makes it extremely vulnerable to injury in mid-shaft humeral fractures. If that bone breaks, the nerve can be stretched, bruised, or even severed. The result is paralysis of all the extensor muscles it supplies distally, the classic wrist drop.
median nerve.
Median nerve, formed from medial and lateral cords, runs down the medial side of the arm, initially lateral to the brachial artery, then crosses anteriorly to become medial to the artery in the cubital fossa, NAT. Generally quite protected in the arm, nestled with the artery. It doesn't give off major branches in the arm itself. Vulnerability increases as it enters the forearm.
And finally, the ulnar nerve, the problematic one.
Often, yes. The ulnar nerve from the medial cord takes a unique course. It runs down the medial side of the arm, but then deviates posteriorly. It passes behind the medial epicondyle of the humerus in a groove you can easily palpate. That's your funny bone.
Right, hitting that sends shockwaves.
Exactly. It's very superficial there. After passing the medial epicondyle, it enters the forearm by passing between the two heads of the flexor carpial nervus muscle, FCU. This passageway is sometimes called the cubital tunnel.
And because it's so superficial behind the medial epicondyle and passing through that tunnel, it's easily injured.
Extremely vulnerable to trauma, fractures of the medial epicondyle, direct blows, and also prone to compression or entrapment within the cubital tunnel syndrome.
What are the specific signs of ulnar nerve injury at the elbow?
You get characteristic sensory loss, numbness, and tingling, paresthesia, affecting the medial 1.5 fingers, the little finger, the medial half of the ring finger, and the corresponding medial part of the palm and dorsum of the hand. Motor loss is also significant. The ulnar nerve supplies the flexor carpial naris, a key wrist flexor and adductor, and the medial half of flexor digitorum profundus in the forearm. Crucially, it also supplies most of the small intrinsic muscles of the hand.
So losing FCU affects wrist movement.
Yes, weakness in wrist flexion, but more noticeably, weakness in wrist deduction, bending the wrist towards the pinky side. When the person tries to flex their wrist, the unopposed action of the median nerve-supplied flexor carpi radialis causes the wrist to deviate towards the radial thumb side.
And the loss of hand intrinsics leads to
The claw hand appearance, especially of the 4th and 5th fingers, difficulty with fine motor skills, weakened grip, and muscle wasting in the hand. Ulnar nerve injuries at the elbow can be quite disabling.
Let's explore a few more specific clinical points related to the elbow and arm structures, building on what we've discussed. You mentioned olecranon fractures with the triceps. What about injuries unique to children's growing bones around the elbow, like a avulsion of the medial epicondyle?
Ah, yes, that's a classic pediatric orthopedic injury. It typically happens from a fall onto an outstretched hand that causes a severe valgus force at the elbow, essentially forcing the elbow to bend sideways, abducting the forearm relative to the arm.
And because the bones aren't fully fused, the attachment point breaks off instead of the ligament tearing.
Precisely. In children and adolescents, the epiphysis, the growth center for the medial epicondyle, is one of the last around the elbow to fuse with the main shaft of the humerus. Fusion might not be complete until the late teens or even age 20. Before fusion, the cartilaginous epiphyseal plate, the growth plate, between the epicondyle and the humerus is structurally weaker than the strong ulnar collateral ligament, UCL, which attaches to the medial epicondyle. So when that valgus stress puts tension on the UCL, instead of the ligament tearing, which is more common in adults, the ligament holds firm and pulls the entire bony fragment of the medial epicondyle off the humerus.
An avulsion fracture. And that needs fixing.
Often it does, especially if the fragment is significantly displaced or if it gets pulled into the elbow joint itself, blocking movement. It usually requires surgical pinning or screwing back into place to ensure proper alignment and future stability, and, importantly, to protect the nearby ulnar nerve, which can sometimes be injured concurrently.
Okay. Now, switching focus to tendons and their sheaths. You mentioned the biceps tendon runs in the shoulder joint. What about inflammation of these tendon sheaths, tendinosynovitis? Can issues there cause problems further down, like in the wrist?
Yes, definitely. Many tendons, particularly where they pass under ligaments or through tight tunnels, are enclosed in synovial sheaths. These are like double-layered sleeves containing synovial fluid, allowing the tendons to glide smoothly with minimal friction.
Like lubrication.
Exactly. But if these sheaths get inflamed, perhaps due to overuse, infection, like from a puncture wound, or systemic inflammatory conditions, you get tenosynovitis. This causes pain, swelling, sometimes a grating feeling, crepitus, along the tendon's path.
And how can inflammation, say around the flexor tendons coming from the forearm, cause problems specifically at the wrist, like carpal tunnel syndrome?
Well, many of the long flexor tendons traveling from the forearm into the hand pass through the carpal tunnel at the wrist. They share this tunnel with the median nerve. These tendons are often enclosed within a large, common flexor synovial sheath. If this common sheath becomes inflamed and swollen, tenosynovitis, or if a localized swelling like a synovial cyst, sometimes called a ganglion cyst, develops from the sheath within the wrist area, it takes up space within the already confined carpal tunnel.
Increasing the pressure inside the tunnel.
Precisely. The carpal tunnel is a rigid space defined by the carpal bones and the overlying transverse carpal ligament. Any increase in the volume of the contents, like swollen tendon sheaths or a cyst, will increase the pressure inside. And the structure most vulnerable to this increased pressure is the softest one, the median nerve.
So the nerve gets compressed.
Right. Compression of the median nerve within the carpal tunnel leads to the classic symptoms of carpal tunnel syndrome: pain, numbness, and tingling, paresthesia, primarily affecting the thumb, index finger, middle finger, and the lateral half of the ring finger, the sensory distribution of the median nerve in the hand. It shows how pathology in one structure, the synovial sheath, can directly impact another, the nerve, due to the constraints of anatomical compartments.
A clear link between structure, function, and pathology. Lastly, let's touch on reflexes for assessment. The bicipital myotatic reflex, or biceps jerk, what exactly is that testing?
The myotatic reflex, or deep tendon reflex, DTR, is a fundamental part of the neurological exam. It tests the integrity of a specific reflex arc, which involves a sensory nerve, a specific segment or segments of the spinal cord, and a motor nerve. Tapping the tendon stretches the muscle spindle receptors within the muscle, sending a signal up the sensory nerve to the spinal cord. This directly synapses with a motor neuron, which sends a signal back down the motor nerve, causing the muscle to contract briefly. The bicipital reflex specifically tests the integrity of the C5 and C6 spinal cord segments and the afferent and efferent pathways associated with them, primarily via the musculocutaneous nerve.
And how do you perform it?
The clinician usually supports the patient's partially flexed elbow. They place their thumb or finger firmly over the biceps tendon in the cubital fossa to locate it accurately. Then they strike their own thumb finger sharply with a reflex hammer.
And you're looking for
a brief, visible or palpable contraction of the biceps muscle, resulting in a slight jerk or twitch of forearm flexion. An absent reflex, oriflexia, a diminished reflex, hyporeflexia, or an exaggerated reflex, hyperreflexia, can all indicate neurological pathology. It might be at the level of the spinal cord segments, C5, C6, along the peripheral nerve, musculocutaneous, or sometimes it can indicate an upper motor neuron lesion if reflexes are generally hyperactive. It's one piece of the diagnostic puzzle.
Right, so wrapping up this deep dive, we've journeyed systematically down from the shoulder girdle. We really dissected the axilla, not just as the armpit, but as that vital pyramidal conduit. We detailed its boundaries, the crucial axillary sheath.
The axillary artery with its 6 key branches following that 1-2-3 pattern relative to pectoralis minor, and the critical importance of collateral circulation, especially around the scapula, and the surgical implications of ligation points.
We also mapped the axillary lymph node groups, that essential drainage system, and then delved deep into the brachial plexus, its roots, trunks, divisions, and cords.
Emphasizing that topographical principle, how C5-C6 control proximal movement, CH.3 control the hand intrinsics, and how the functional split into anterior, flexor, and posterior extensor compartments happens right at the level of the divisions.
Leading to the cords wrapping around the artery and ultimately giving rise to the major nerves, like the musculocutaneous, median, ulnar, axillary, and radial.
Then we moved into the arm itself, defining its anterior, flexor, and posterior extensor compartments separated by the intramuscular septae. We looked at the muscles within each biceps, brachialis, coracobrachialis up front, triceps, and aconius behind.
Highlighting things like the biceps' role in supination, the brachialis is the flexor workhorse, and the triceps' long head stabilizing the shoulder.
And finally, we traced the neurovasculature through the arm, the brachial artery's palpable course, its relationship with the median nerve, the key profunda brachibranch. We covered the superficial veins like cephalic, basilic, and the vital median cubital, and the deep brachial veins with their countercurrent heat exchange function.
Finishing in the cubital fossa, that triangular space with its NAT contents, median nerve, brachial artery, biceps tendon, and noting the vulnerabilities of nerves like the radial and the spiral groove and the ulnar behind the medial epicondyle.
It's a dense region, but understanding the layout is key to clinical practice.
Absolutely. So our journey continues distally next time. The anatomy just keeps getting more intricate. Join us then as we move into the complexities of the forearm. We'll examine its complex arrangement of flexor, pronator, extensor, and supinator muscles, everything working together to give us the incredible dexterity of our hands.
And maybe, as a final thought to ponder from today's discussion, reflect again on that brachial plexus reorganization. Think about the sheer efficiency of routing all the extend signals through the posterior divisions into that single posterior cord highway. How might our function or our recovery from injury be different if the body hadn't evolved this strict compartmentalization of nerves and muscles right from the start? It really makes you appreciate the elegant functional engineering embedded within our anatomy.
Something to definitely think about. Thanks for listening to Bookfulness.